Good afternoon or evening, and welcome to Elders Climate Action's monthly national call for April. My name is Mark Cook, and I'm one of three co-chairs of ECA's Education Committee. Thanks for attending. We're glad you're here. Early this month, the United Nations Intergovernmental Panel on Climate Change, also known as the IPCC, released the report of the Third Working Group on Climate Change Mitigation. 2 months ago, at the end of February, the IPCC also issued the report of Working Group 2's contribution to the IPCC's overall sixth assessment. We know that so far, actionable responses to these findings and reports are not even close to being fully commensurate with the enormous magnitude and stakes of climate change. It is my pleasure to introduce our presenter tonight, Dr. Kristie L of the University of Washington's Department of Global Health, who is a lead co-author of that February IPCC report titled Impacts, Adaptation, and Vulnerability. Along with her co-lead, they produced Chapter 7 titled Health, Well-Being, and the Changing Structure of Communities. Dr. L was also a drafting contributing author of the summary for policymakers on the general findings of the Third Working Group she was part of. In addition, Dr. L is also the air quality chapter lead for the 4th U.S. National Climate Assessment. For the benefit of new attendees and as a reminder for our loyal recurring audience members, the basic format is that Dr. L will present for the first part of our time together, and after that, there will be an opportunity for you to ask her your questions. Please post your questions by using the Q&A button at the bottom middle of your screen. We anticipate wrapping up by 8 p.m. Eastern Time. Dr. L, thanks for sharing your time and critical work with us. The stage is yours.
Thank you very much. And I really appreciate the invitation to talk with all of you. Really appreciate your interest in the IPCC reports and specifically on climate variability, change, and health. Apologies for the dark glasses. I went to the eye doctor today and got my eyes dilated, and it's quite sunny outside right now. I want to start with some framing. On the right-hand side is a framework that's been used for the last decade in IPCC reports. When we look to the future, we're looking at risk, where risk is probability times consequence. When you break risk apart, there's three major components. One are the hazards created by a changing climate. The second is who or what is exposed, coastal communities, people susceptible to heat waves, for example. And the third are the underlying vulnerabilities. And this includes inequities, it includes geographic location, and it includes the capacity to manage at local to national scales. And so it's important to keep that framing in mind, because when we talk about climate change, we don't just talk about climate change. We have to talk about the exposure and the vulnerability as well. The figure on the left is a basic outline of how climate change could affect our health. The top row shows that increasing our greenhouse gas emissions is rising temperatures, increasing the frequency, intensity, and duration of extreme weather and climate events, increasing sea levels, amongst a range of other factors. Based on the figure on the right, those then interact with a broad range of demographic, socioeconomic, environmental, and other factors that then determine where we see climate sensitive health outcomes and how severe they are. Underneath that are exposure pathways, and these are the kinds of things that we study in health. You can see extreme weather events, heat stress, air quality, on across to social factors. Underneath is a short list of all the climate sensitive health outcomes. I'm calling these health outcomes because disease is inappropriate. People are injured, for example, in flooding events, and that's not a disease. So we call them health outcomes. It's a very long list of climate sensitive health outcomes. I've had the privilege of spending a fair portion of my life in low and middle income countries, and these are all of the issues that ministries of health deal with. Climate change is a cross-cutting issue that touches on almost every department within a ministry of health. Let's see if we can make this go forward. There we go. I think I skipped a slide. This forward and back button doesn't work well for some reason today. This is very word dense, and I apologize for that, but the human health chapter in the 6th assessment report is comprehensive. It's mandated to be comprehensive. One of the areas we looked at is where do we know that there are observed impacts from the climate change we've already seen. As you know, the Earth has warmed about 1.1 degrees Celsius above pre-industrial, almost 1.5 degrees Fahrenheit. And associated with that are a range of changes to human health and well-being. You can see the headline statement, climate change is adversely affecting the physical health of people globally and the mental health of people wherever there were data available to assess. In the lighter blue, I've listed some of the major categories of climate sensitive health outcomes for which we have information. One of the themes you'll hear throughout this is one of the significant constraints we face in this area is the almost complete lack of funding. When you look at funding under the National Institutes of Health here in the United States, they've been funding this research at about 0.02 to 0.04% of their budget. It's not much larger in Europe, although this year Europe did fund several large projects on climate change and health. Similar challenges in Australia. When Justin Trudeau was named Prime Minister of Canada, he increased the funding in this area. So Canada's got more funding than most countries. And this chronic low level of funding means I showed you a list of all those possible climate sensitive health outcomes, examples of climate sensitive health outcomes. And for many of them, we just don't have any studies. We just haven't been able to do that without funding. When you look at each of the statements, the number of stars is the level of confidence that we've already seen impacts from climate change. I will talk about a few of these going forward. If you've got questions on any of these, I'm more than happy to help provide some responses. And I did want to note that this was the first time that the Human Health chapter in the IPCC did a comprehensive assessment about how climate is affecting mental health and well-being. And I'll give some examples. I hope you've seen this before. Every year, the US National Oceanographic and Atmospheric Administration, or NOAA, tracks billion-dollar disasters. These are the billion-dollar disasters last year through September. Overall, last year, there was $23 billion disasters that cost the US something in the order of $50 billion. So one point is when you hear that we can't afford to address climate change, we can't afford not to. These are only the billion-dollar disasters. They're not the $100 million disasters, the $10 million disasters. It's only the very top level of disaster. And further, these are only insured losses. So these are disasters in terms of the impacts on infrastructure. Does not take into account impacts on our health. And I'll show you some of those as I go forward. I mentioned a moment ago mental health. When we think about extreme weather and climate events, this is where there is research. There's been very well done studies in England looking at some flooding in the southeast several years ago. And you can see that the difference in the prevalence of probable depression, anxiety, and post-traumatic stress disorder after the flooding event, really significant differences between people who lived in a residence that was flooded versus people who lived in a residence that was disrupted. Floodwaters came to the front door but didn't go in, versus those in residences that were not flooded. These people have been followed up for 3 to 4 years now. And even 3 years later, the prevalence of these mental health problems declined significantly, but there's still differences across these 3 groups. And this tells us then that as we have more and more extreme weather and climate events, that we're going to have to pay more attention to these mental health problems for long periods of time. One particular extreme weather and climate event is heat waves. I'll spend a few minutes talking about heat waves. Exposure to heat waves has been increasing. And this shows you on the left from 1980 till 2020, the exposure in terms of person days of exposure for adults over the age of 65 and for children under the age of 1. And you can see that for adults over the age of 65, in 2020, there was 3.1 billion more person days of exposure worldwide than there was over the long-term average. Adults over the age of 65 are amongst those that are most susceptible to high temperatures. Our body has a range of mechanisms to protect ourselves when we are exposed to high temperatures. What we're concerned about is our core body temperature. Our cells and our organs operate within a pretty narrow range. And so our body has a range of ways to try and decrease our body temperature when we start getting too hot. And this includes, of course, behavioral change of going and finding a shady place to sit, trying to find someplace cool, turning on a fan, increasing air circulation in a residence. And if we can't keep our core body temperature down, as it starts to rise, we start seeing a range of adverse consequences on our cells and on our organs. When you look after a heat wave, about 50% of the excess deaths are due to heart disease, due to some kind of heart attack, some kind of cardiovascular event. Because there are so many ways that it's possible to bring down that core body temperature, and because of the understanding of the various ways that our body does handle higher temperatures, you can say that all heat-related deaths are potentially preventable. People don't have to die in a heat wave, and yet they do. A study came out last year looking at what proportion of all the summer heat-related mortality could be attributable to climate change itself. This looked over 43 countries, more than 700 locations in those countries. And overall, the estimate was more than 40% of current and recent heat-related mortality is due to changing climate. And these are people, as I just said, that would not have died without these heat waves. So we can start talking about people who are actually dying from climate change. And when you look at the figure, you can see quite a difference across countries, that there are reasons for those differences, the prevailing weather patterns, but also the infrastructure and the culture. There's lots of opportunities to decrease this appalling loss of life from higher temperatures. I live in the Pacific Northwest. At the end of June, we had a heat dome that you may have heard of. This shows you how much we broke our temperature records by. If you follow your broadcast meteorologist, you know that wherever you live, that typically when records are broken, they're broken by tenths of degrees. And you can see that in this region, temperature records were broken by more than 10 degrees. That was unheard of. There's a formal process called detection and attribution that was applied to this event. And the conclusion was this event was virtually impossible without climate change. The current estimate, although there's research going on to refine it, is that more than 1,000 people died. Again, these are people who would not have died without that heat event. The hospitals were overwhelmed. There was a 69-fold increase in the hospital admissions in our region. We had a webinar across our emergency departments, just hearing the stories of how difficult it was to manage all of the people that were coming in. And this, of course, was on top of COVID. In addition, this heat event occurred during the height of our cherry picking season. We're one of 3 states in the United States that has protection for outdoor workers. And so there's a lot done to protect our outdoor workers, but those temperatures well over 100 degrees almost never occur in Seattle. We had temperatures that have never occurred in our region. In addition, the heat dome occurred at low tide, and between Seattle and Vancouver, the estimate is about 1 million mussels and clams were cooked. And these were unprecedented for coastal tribes because this represents their livelihoods and their food security. Heat is an all of society problem and needs to be addressed more comprehensively than is occurring at the moment. I'm going to stop for a second because I can see that there's a couple questions in the chat. Did you want me to address those now or later?
Actually, we don't have any questions in the chat right just yet. So that was
Okay.
us, asking people to put their questions in.
Okay, great. I just popped up, right?
It's
2 questions in the chat.
no problem.
I live in the Pacific Northwest, so when you think about heat, you think about wildfires. And this is another figure from the Lancet Countdown that follows 40-some indicators of climate change and health published every year. And you can see, just as with heat waves, a very large increase in the number of days when people were exposed to very high or extremely high fire danger. Recent research is showing that when we think about wildfires, when we talk about the smoke, it's measured as a particular size of particulate matter, PM 2.5. But that wildfire smoke is more toxic than just measuring the size of the particles in the air. There's lots of research showing hotter years, higher wildfire risk. And this just goes to the beginning of 2019. There's many of you who are in regions right now that are experiencing wildfires. And wildfire smoke causes health risks. I put this in because, number one, it shows the increase in risks for diabetes, lung, and heart disease, but also the air quality index. And again, this is a measure of the number of particles in the air of a particular size. And you can see as you get up to about 60 of these particles, they're in micrograms per cubic meter, that the air is unhealthy for anyone to breathe. 2 summers ago in Seattle, we had, for 2 solid weeks, we had wildfire smoke blowing into Seattle. The sky was yellow from morning till night. We never saw a cloud, we never saw the sun. And in my neighborhood, the air quality index was over 250. There were wildfires around Los Angeles this last summer. One of those communities measured an air quality index of over 750. These exposures are very large, and there's research going on to better understand what it means for our health. But we do know that people who have any kind of lung disease, children, are much more susceptible when you're breathing this really unhealthy air. I've got 3 slides from a study that just came out from British Columbia, because it's a useful approach to being able to think about how to better manage these intersecting risks. We call them compounding and cascading risks. And this shows for British Columbia, there was a team that looked at developing indicators of exposure to very high temperatures, looking at the communities and the individuals more sensitive to those exposures, adults over the age of 65, people who've got chronic medical conditions, people who take certain drugs are more susceptible to the heat. And also looked at the capacity of the communities to manage those higher temperatures. Do you have a heat wave early warning system, for example? Do you have ways to help protect people in elderly care institutions to make sure that they keep their core body temperature where it needs to be? But they didn't stop there. They also looked at flooding and sea level rise, wildfire smoke, and ground level ozone. Ozone's formed on clear cloudless days. The rate at which it's formed is temperature dependent. All else being equal, with higher temperatures, there'll be more ozone, which is a lung irritant and is a problem for anyone with chronic obstructive pulmonary disease, for example. And then the authors put it all together and created this vulnerability mapping for these compound hazards across British Columbia, identifying the places where it's urgent and immediate that action be taken. And this is a way to start prioritizing how we're going to take the limited funding we have available for adaptation and focus on the people and the places that are most at risk. If we were in person, I would ask how many people have allergies or asthma. Usually it's at least a third. The map of the US and Canada on the left shows you over the last couple of decades the change in the ragweed pollen season. You can see up in Alberta, almost a month longer season. So we know that the pollen season's starting sooner, lasting longer. The top right shows you that higher concentrations of carbon dioxide lead to more pollen. And I'll talk about the mechanism in a couple of minutes. So you've got longer seasons and you've got more pollen. Unfortunately, this is also true for plants like poison ivy, where experiments have shown that under higher CO2, there's more of the toxic oils in poison ivy. This is an area where medical professionals in allergies and asthma are paying more attention because they're starting to see more patients show up with severe allergies and asthma, showing up earlier in the year, later in the fall. The next major category that we assessed in the chapter was what could happen in the future. I showed you what was observed, and this is projected underwarming of 1.5 degrees Celsius, which is the ultimate goal of the Paris Agreement, 2 degrees Celsius and higher. You can see the list of climate sensitive health outcomes is shorter. This goes back to my comment about really significant underfunding. And so there's been fewer projections for what could happen. But even with that, you can see very high confidence in changes in the number of people who suffer and die in heat waves, people who suffer from foodborne, waterborne, and vectorborne diseases, and then high risk around mental health outcomes, particularly associated with extreme weather and climate events. This is an example of some work that helps tease apart some issues. This shows you the annual heat-related deaths projected later in the century. And usefully, the author Drew Shindell did this so that you can see across the top row, the 3 maps of the US, is an analysis where adaptation to the changes in temperatures is included. So the projections take into account that people will acclimatize to higher temperatures, will change our infrastructure, will develop early warning systems. The bottom row is when there's no adaptation. The columns are 3 levels of greenhouse gas emissions into the future. The left is where our emissions are today. The middle is where there is a modest reduction in emissions, and the right is where there's aggressive reduction. As you look across these, even with adaptation and aggressive emission reductions, there's still going to be an increase in heat-related mortality. This is what we call residual risks after adaptation, after mitigation. There's still going to need to be work by our health systems to be able to manage more people who are going to suffer in heat waves. Obviously, if we don't adapt and we don't mitigate, the map in the bottom left, we see a very significant increase in heat-related mortality projected into the future. Moving on to vector-borne diseases, a topic that people often find interesting. I'm not going to go through this entire slide. I put it in here. It talks about dengue fever, but it also relates to a number of viral diseases that are carried by mosquitoes and pathogens that are carried by ticks. And in green across the top, you can see that temperature and precipitation together affect the development, the survival, and the reproduction of mosquitoes and ticks. Temperature also affects the pathogen itself. So it affects the replication of the pathogen, which then affects its transmission. This means that modeling what we could see in a changing climate is relatively complicated because you have to have both the temperature conditions modeled for the pathogen as well as the temperature precipitation conditions for the mosquito or for the tick. One example is some projections that were done for a mosquito, Aedes aegypti, which is the major mosquito in the US that can carry dengue fever, Zika virus, chikungunya, and yellow fever. In the US, vector control is at the state level. It's not a national level activity. So there's lots of variability from state to state. And that means both of these maps are based on modeling of what is understood about the environmental constraints for this mosquito. In the top left, in the beige color, is the present day suitability for this mosquito. So those are all the places in the US where the environment could support the mosquito. We don't necessarily know whether it's there or not because, again, vector controls at the state level. The red color is the projection towards the end of the century with high greenhouse gas emissions, showing a significant expansion of that geographic range, including Seattle and other parts of Washington, but a very large increase. But it's not just having the right environment for the mosquito. You also have to have a summer that's hot enough and long enough so that if dengue fever, for example, is introduced into an area, there's time for it to get into the mosquito population, to replicate within the mosquito population, and then be transmitted back to another human. And when you take those constraints into account, you can see in the bottom right, still a significant expansion in the geographic range, but nothing like what you see on the left. And I live in Seattle, so this seems like it's pretty good news for Seattle. However, this paper was published in 2016. A couple of years later, breeding colonies of this mosquito were found in Toronto, Toledo, and Detroit. This mosquito is completely adapted to human environments. It can breed in the water in the bottom of a flower pot. It overwinters in our sewer systems. I've not done this, but entomologists, colleagues of mine, have gone into sewer systems and said there's millions of mosquitoes in sewer systems. They're warm, they're moist, perfect places for the mosquitoes. And so it's not a question of, are we going to see the kind of pattern on the left with a big change in terms of where we're going to see this mosquito, but when? And just like other areas in climate change, we're under projecting how quickly things could change and how extensively they could change. The biggest impact of climate change on health is going to be on malnutrition. And that's from two mechanisms. And I'll talk about these separately. The first is that there's around 800 million people in the world who are food insecure. Most of those people in Africa and in India. India has more food insecure people than all of Africa. And the crops that they grow are growing on the thermal edge of their tolerance. And I'm not going to talk about soybeans because soybeans are a legume and soybeans are odd, actually. The top row shows the change in yields in mid-century, and the bottom, the change in yields at the end of the century. And just look at the patterns for maize or corn, rice and wheat. And you just see a consistent decline with higher temperatures. The bars, the color of the bars have to do with greenhouse gas emissions. And the numbers across the top of each graph have to do with the number of studies. But it's just a visual of this real decline in crop yields. And all of these lead to projections of increased numbers of people with food insecurity. The second mechanism is from carbon dioxide itself. Our plants all have mechanisms for bringing in carbon dioxide from the atmosphere, breaking it apart into carbon and oxygen, and then using the carbon to grow. 85% of our plants have one photosynthetic pathway to do this. And based on the biochemistry of that pathway, they're called C3 crops. And it just has to do with this particular photosynthetic pathway. C3 crops include wheat, rice, barley, potatoes, grasses, just about everything that we think of when we think about the plant kingdom and what we eat from it is a C3 crop. And as you can see on the figure that as you have higher concentrations of carbon dioxide, this promotes plant growth. You'll see in the media frequent statements that CO2 is plant food. It's plant food, that's true. However, what is not covered in the media is that as you have more carbon in the plant, you have more carbon-based molecules in the plant, which means you have more carbohydrates. And at the same time, you've got less nitrogen-based compounds. Based on experiments that are done where you have a field of wheat or rice and you blow carbon dioxide over some parts of it and not over others, you see about a 10% reduction in protein, about a 30% reduction in B vitamins. Separately from that, plants that have been grown under higher concentrations of carbon dioxide are more water efficient. They don't need as much water to grow. And that means the crops bring in less nutrients from the soil, the iron, the zinc. I mentioned there's about 800 million people in the world who are food insecure. There's about 2 billion that have micronutrient deficiencies. And that includes about 1.5 billion women and girls who've got iron deficiency anemia. All of the projections of the consequences of higher CO2 concentrations on the nutritional quality of our food indicate that later in the century, hundreds of millions of people are likely to be affected. When we think about what it is we need to do, one step obviously is mitigation. And this is from the Working Group 1 report, came out several months ago. And it's just to make the point that every ton of emissions adds to warming. And there's this linear increase from historic warming shown in the squiggly line, projecting out through various pathways of greenhouse gas emissions into the future. So every emission matters. And one of the activities the IPCC has done for the last 20 years, it started, well, I guess 21 years. So it started in 2001. There was an effort to try and understand what it means to prevent dangerous anthropogenic interference with the climate system. Article 2 of the United Nations Framework Convention on Climate Change says that's its ultimate goal, prevent dangerous anthropogenic interference with the climate system. Dangerous, of course, is not a scientific term. I think skydiving is rather dangerous, but I know people who really love it. And so the UNFCCC, United Nations Framework Convention on Climate Change, turned to the IPCC to say, how are we going to think about dangerous? The third assessment report spent a lot of time thinking about how to frame that question and came up with what are called reasons for concern, RFCs, reasons for concern. And said there's 5 reasons for concern for dangerous anthropogenic interference with the climate system. The first is unique and threatened systems. Think about coral reefs, for example. The second, extreme weather and climate events. We've seen a lot of those. I don't think I need to talk about those. The third is on the distribution of impacts. And this gets to the inequities of small island developing states, for example, are in the front line of sea level rise. The fourth is adding up all the impacts. What does the total look like when you start adding all the impacts together? And the fifth, large-scale singular events, is about melting of the West Antarctic ice sheet. It's large changes in our systems. When you look at the figures, the 0 line is pre-industrial temperatures. The y-axis is increases in global mean surface temperature above pre-industrial. The program we use to generate these figures uses those dots for confidence levels. The more dots, the more confidence. They're fairly distracting and there's nothing we can do about it. The gray bar is where we are with current temperatures. And the color scheme tells us scientifically quite a bit. And this is based on all of the literature that we assess. Where the temperature is white, it means it's not possible scientifically to say whether there's been a change, for example, in unique and threatened systems. We don't have enough data, there hasn't been enough change, or there hasn't been a change. We can't tell. When the color turns to yellow or gold, it means, yes, that system has changed, and we can attribute at least part of that change to climate change. When the color turns to red, it means the risks are high. When the color turns to purple, it means the risks are very high. Because of the color scheme, those of us who work on these call the figures the burning embers, because it's kind of what they look like. I didn't put in a slide, but one of the advantages of using this scheme across all of the IPCC reports is you can compare over time. And there's been a significant shift since 2001, when the first reasons for concern were published, in terms of seeing much more impacts much closer in time. There's been a real dramatic shift and the risks are getting much greater. And with that as an explanation, then these are the burning embers for health. And you can see, we actually have 6 of them in the report. We have 4 of them in the summary for policymakers: heat-related mortality, ozone-related mortality, malaria, dengue, and all of the other diseases carried by Aedes mosquitoes. We also did our assessment looking at 3 levels of adaptation. So in each set, the figure on the left is a world with very limited adaptation. The figure in the middle is for a world that continues along our current trends. We try to adapt, we're not doing it fast enough, we're not keeping ahead of climate change. We make some efforts, but they're incomplete. And the figure on the right is a world aiming sustainable development, that there's real efforts at mitigation and adaptation. And as you look at these figures, hopefully 2 things jump out at you. One is how important it is that we mitigate. And the second is how important it is that we adapt. I should have mentioned that the figures for incomplete and proactive adaptation are truncated at the projections for the Working Group 1 report. So the proactive adaptation, a world aiming to sustainable development, that under that scenario, the temperature change in 2100 is around 2 degrees C. For incomplete adaptation, where we have moderate emissions and we do some efforts at mitigation and adaptation, under that scenario, the projected temperature change in 2100 is 3 degrees C. And that's why those are truncated. But you can see the real differences across these climate sensitive health outcomes. These are not the most important climate sensitive health outcomes, but they're ones where we had projections that we could use to create the burning embers. And hopefully by the next report, we'll have many more examples. When we think about our health systems, where our health systems includes both of our public health, our laboratories, those kinds of activities, and our healthcare, those together are health system, that our health systems are being affected by climate change. So it's not just our health, but also our health systems. So our health systems are experiencing stresses and shocks, which then decrease the performance of our system. People don't have access to care. The hospitals become overwhelmed. The kinds of issues we see and have seen for the last 2 years with COVID are what we're concerned about with climate change. The question is, how prepared are we going to be? And when we have these events, then we'll be able to transform our systems to those that are climate resilient and environmentally sustainable, recover better than before, or something much, much worse. And there's lots of efforts by the World Health Organization to ensure that we build our resilience to a changing climate so that we don't end up worse than before. In terms of adaptation, another very dense word slide. I didn't want to put in figures for all of these. It's a lot to cover in a short amount of time. But you can see there's a wide range of effective adaptation options. And I've listed some of those here, and happy to talk about those in the Q&A. As I mentioned before, funding is a major constraint. When you look at the funding for adaptation under the United Nations Framework Convention on Climate Change, less than 0.5% is going to health. So at the same time, we're seeing people suffering and dying from climate change. We're not getting the investments we need in our health systems to be able to strengthen those and really help ensure that we protect and promote population health, even in the context of a changing climate. One major activity at the national level is to have national adaptation plans for health. The World Health Organization does a survey every other year. These are results from 2021. And you can see about half of the countries that reported had some kind of national health and climate change strategy or plan in place. But less than a quarter of the countries felt that they were doing enough in terms of implementation, with a major constraint, again, funding. And there's lots of examples of adaptation plans. Heat adaptation plans are critically important. You've got a poster on the left from Quebec of what people can do when it's really hot. I put in the example from India. It's a place in India that's close to Pakistan. It's really hot and it's really dry. And they have a really effective plan that they've put in place to really make quite a difference. The headline on the bottom is about inequities. In the US, we know that red line districts are hotter than the surrounding areas. Many of the people living in them are more susceptible to the heat because of higher levels of chronic disease. And so heat is a real big inequity issue that needs to be addressed as we develop our heat action plans and our heat wave early warning and response systems. Similarly, for vector-borne diseases, there is a lot we can do in terms of developing early warning systems that will give us a lot more time to be prepared for when the weather patterns are ripe for having an outbreak. This is an even busier slide. It makes several important points. When we think about mitigation, think about reducing our greenhouse gas emissions, three major categories are reducing emissions from coal-fired power plants, shutting down those power plants. About 7 million people worldwide die every year from air pollution. And so decreasing those emissions means that you are improving human health. A second major category is around transportation, reducing the number of internal combustion engines in our cars, in our buses. And one way to do that is to get people out walking and biking. And when people walk and bike, they feel better, they reduce their blood pressure, they lose weight, and there's positive health consequences for that. A third major category is around our diet, that producing particularly red meat leads to very high emissions of methane, a powerful greenhouse gas. And if you get people to eat no more red meat than their doctor recommends, then you can reduce the amount of beef, the amount of other kinds of meat that's produced, and that reduces those greenhouse gas emissions. It also makes people healthier. And when you start valuing the number of avoided hospitalizations from exposure to air pollution, the traffic, the meat, the number of avoided premature deaths, and you value those, the value is of the same order of magnitude, if not larger than the cost of mitigation. We almost never hear this out in the public. When there's talk about mitigation, there's always talk about how much it's going to cost. There's never a companion statement about, and we're going to save that much money in terms of our healthcare costs, in terms of people have longer and healthier lives. There's a lot of work in the health sector trying to get this information out so it can be used by our policymakers. One of many examples is from the US Regional Greenhouse Gas Initiative in the Northeast. And this just shows the economic benefits of avoided cases of adverse child health outcomes over a 5-year period. And you can see that in some of these counties, the value is up to $21 million. It's huge benefits that can be achieved through mitigation. And the more we can help policymakers understand the benefits that will accrue from mitigation, the more we hope that will move policy. I put this in mostly because I really think the photograph is amazing. It's an example from Australia and how shifting just 5% of short urban car trips saves fuel, saves lives, and saves a lot of money in healthcare costs. And finally, I keep mentioning that we don't have enough funding. We're far from having even minimal funding. We've got a very big research agenda that needs to be addressed. And hopefully some of this research agenda is going to be addressed by the time we get to the next IPCC report. When we think about climate change and health, about 85% of the impacts of climate change and health are in children. In the US, when you say climate change, people tend to think polar bears. And I really hope that after this, you'll remember it's the children who are being affected the most. Thank you very much for listening, and I look very much forward to your questions.
Thank you very much for that great presentation. And we do have some questions. First question is there a positive relationship between climate change and pandemics?
That's a really good question. If you're thinking about COVID, the answer is we don't know. There doesn't seem to be any evidence that climate change itself has affected COVID, but there's lots of ways that climate change is changing, for example, the geographic range of bats, and bats carry a lot of viruses that could potentially cause pandemics in humans. And so, yes, there's ways that it's likely that that will happen. We haven't seen it yet.
Thank you. Our next question is, what percent of our effort for adaptation versus mitigation of global warming will lead to the smallest number of deaths?
It's another very good question. They're equally important. We cannot privilege one over the other. That if we only mitigate because of the inherent inertia in the climate system, people are going to suffer and die for decades until there is a difference in our weather patterns. If we only adapt, then we're just going to create a terrible world for our children and our grandchildren. We have to do both. And the commitment under the United Nations Framework Convention on Climate Change is that funding will be 50-50. and that we just have to say both are equally important and we have to do them both.
That makes a lot of sense. So who can we target to request more funding for research on climate and health?
It's a very good question. President Biden, in his budget that was passed a couple of weeks ago, had put in $110 million into the National Institutes of Health for climate change and health, and put $110 million for the Centers for Disease Prevention and Control. And something happened in budget reconciliation and it came out of both. So there's no funding in his budget for this area. As I said, there's been almost no funding in this area for decades. So somehow getting through to our various congressional representatives that this is an area that's important, people care about it, and it needs to be in the budgets.
Something to add to our to-do list. Yeah, please put your questions in the Q&A rather than in the chat. But we have a good question from the chat. What are the health risks from melting permafrost?
There's a lot of speculation about that. People like to talk about that because we don't actually know what's locked up in permafrost. Well, we do know there's a lot of methane in permafrost, and that will be potentially catastrophic as all that methane is released out of permafrost. There's lots of concern that there's viruses and other pathogens in the permafrost that could be released into the world when the permafrost melts. It is a topic often discussed. We just don't really have any evidence of what's in the permafrost. So there's no way to assess how big a problem that could be.
So another question about evidence a little closer to home. Is there any evidence that promoting community gardens and or backyard gardens can provide health-related mitigation and adaptation benefits?
I think that those have tremendous potential. And there's a lot of interest in various parts of the world to promote the community gardens and making sure that as people have their gardens, that they use it to increase the nutrient density of their diets. And so making sure that you're thinking about the whole range of foods that we know are good for our health. And if you don't get those from the market, then grow them in your own yard, I think is a great approach. The challenge, one of the big challenges, of course, is this is primarily a middle-class activity, and how to benefit our disadvantaged colleagues, our disadvantaged citizens that don't have that opportunity to grow gardens, often don't have access to the kinds of markets the middle class is used to. That when you look at low-income areas in the US, many of them are labeled as food deserts. They don't have any grocery stores. What they have is a 7-Eleven or some equivalent thereof. And finding ways to really help promote their health and their well-being, reduce the inequities that resulted in so many of them being there in the first place, is a priority activity.
And we're always looking for ways to engage elders in the fight against climate change. Do you feel that this is an issue around which elders can be organized?
Yes. One place that would be very helpful, I know that you're working on, and I assume you know about the 6 Americas. This is a long-running survey that Yale's been doing, asking the American public their opinions around climate change. And the latest results are pretty surprising if you only get your news about what the Americans think about climate change from the news media. 75% of the US population agrees the climate is changing. 2/3 are worried about it. 50% thinks climate change is affecting their health. So the numbers are actually pretty high across the US. Interestingly, though, the survey a couple of years ago started asking a new question, is how often do you talk to anybody else? And less than 1/3 of Americans talk to anybody else about climate change. So 2/3 are worried about climate change and they don't talk to anybody. And finding ways to get those conversations started. And people will be surprised how many people are concerned, How many people are hungry for information but don't know where to get it? And so there's tremendous opportunity. And I know that a big part of what you do is advocacy, but if you start building the understanding across the population, you're starting to move towards advocacy, because then people will start doing things like voting for what they're concerned about. And we know they're concerned about climate change.
It's a great point. Another question about, what is your opinion about the value of carbon capture technology?
That's a very complicated question. It's one of those technologies that's been showing promise for 20 years and is not being deployed at scale. It's going to take decades to deploy it at scale. On the other hand, when I spoke a little bit earlier, every ton of CO2 matters. Every action to reduce those emissions matters too. And when we look at the basket of technologies we're going to need to deploy, we're going to need to deploy all of them. They're all going to have a role to play in bringing our emissions down, from turning our own lights off, from making sure our computers go to sleep, we don't leave them on all the time. There's lots of things we can do as individuals, and then there's lots that industry can do in terms of getting emissions out, and carbon capture and storage is one of the ways that's likely going to be used.
I think we've got one last question. That's about EPA's proposed truck and bus standards that don't require manufacturers to switch to zero emission technologies. And do you think ECA should ask the EPA to set zero emission standards for new trucks and buses?
Is there a call for comments from EPA right now on this? I know there's a call from EPA for comments on something.
Yes, there is one currently on that.
Yeah, and it's certainly, EPA does welcome all comments, and they do become public. And so it is worthwhile to put comments in whenever there's an opportunity.
Yeah, I think, unfortunately, I think we're running out of time for more questions. So I'm going to turn things over to Mark.
Okay, Jen, before I close this out, did you want to talk a bit more about what we were just talking about and an action from this?
Sure, absolutely. Well, thank you so much for joining us. This has been a very informative call. And of course, we want everybody to go away with an action to take. And so a really important action right now that we're working on within ECA is getting our members to submit comments to the EPA. And we've made that easy for you. We've drafted a template of a comment with all the links that you need in order to submit your comments. So I'm going to drop that in the chat box. And if everybody can make sure that they take the time to submit a comment to the EPA, we can really make sure that we can move forward with zero emissions vehicles. So thank you for joining us, and I'm going to turn it back to Mark.
Okay, well, thanks again, Dr. Ebi. If there's an opportunity for ECA to amplify your message, particularly as it pertains to funding, we hope you'll let us know. It is days away, but May is National Clean Air Month, first organized by the American Lung Association 50 years ago. In next month's National Call, we will feature Dr. Juan Antonio Aguilera of Stanford University. And by the way, thanks for your recommendation, Sheila, if you're on. Dr. Aguilera's research focuses on the impact of wildfire smoke on cardiorespiratory and immune health and traffic-related air pollution, also relating to the action we just spoke about. We hope you will consider a sustaining or other contribution to ECA and its ongoing work. This concludes tonight's event. Thanks for your interest. Have a pleasant evening, and we hope you'll join us next month. Good night.